Welcome to UMDF's Ask the Mito Doc monthly webcast. Tonight we will hear from Dr. Hilary Vernon, Dr. Reed Thompson, and genetic counselor Rebecca McClellan from Johns Hopkins University School of Medicine. Our moderator this evening is our very own Margaret Moore, UMDF Support and Education Associate. The floor is yours, Margaret.
Welcome everyone to our February Ask the Mito Doc. We will be it's Heart Month, so we are featuring cardiac issues and the mitochondrial disease patient, which is kind of exciting. We look forward to hearing what Dr. Vernon, Dr. Thompson, and Rebecca McClellan have to say, but we have a little bit of housekeeping to move on to next. We always have to thank our sponsors, ESL Trees, Charitable Trust, and UCB for supporting our Ask the Mito Doc webcast series. It's time to get started. I would like to invite Dr. Vernon, Dr. Thompson, and Rebecca McClellan to join us. Hello, everyone.
Hello.
Thank you for being here and helping us celebrate Heart Month and help our families get this much needed education on this important topic. We're looking forward to hearing all about what you're going to teach us today. So I'm going to go off screen and let you take the reins.
Great.
Thank you, everyone.
Hi there. It's a pleasure to be here, and thank you for having us here to speak tonight. As you heard, myself and Reed and Rebecca are going to be discussing cardiac management in primary mitochondrial diseases. The three of us have been working together for more than a decade in taking care of patients with mitochondrial conditions. So we're going to start with a case presentation that Reed, Rebecca, and myself have a patient that we've been taking care of for quite a long time. This is a young lady who was born to a typical pregnancy, weighing 6 pounds and 3 ounces. Early in life, her parents noticed that she had some issues with feeding, a distended abdomen, and she really didn't gain weight very well. She had delayed gross motor skills. She had delayed rolling over, delayed walking, delayed running, but she had typical fine motor skills and typical language development. She did very well in school. Leg muscle weakness was actually noted by her family around 18 months of age. Then particularly starting around 3rd grade, she and her family noticed that she was having a hard time keeping up with her peers in gym class, and she was having a lot of fatigue. At 9 years of age, she presented to the cardiology clinic, and she had concerns of exercise intolerance. She was dizzy. She felt like her heart was beating very quickly, and she was vomiting after exercise. She was also at the time noted to be very short, quite short and light, low body weight. Family history, there was really nothing sort of particular that was running through the family. She had a healthy 7-year-old sister, and her parents were doing well with no heart problems. At the time, an echocardiogram showed enlargement or left ventricular hypertrophy of the left ventricle of the heart. Looking at rhythm, the rhythm at the time was normal, but because of the left ventricular hypertrophy, she was started on atenolol and a beta blocker and given some exercise restrictions. And at that time, it was also recommended, because we weren't sure what the etiology was, that her parents and sister had echocardiograms, and those were normal. At age 14, some blood work started to show that she was developing a metabolic acidosis. And these are just some labs that are evident of that. And she was started on an additional blood pressure medication on carvedilol. Because she was having continued worsening of her heart function at that point, the potential for a future transplant was discussed. She had a heart catheterization, and it looked really consistent with a mitochondrial disorder. The mitochondria themselves on the biopsy were increased in number. The mitochondria were malformed. And at that point, the patient was referred to cardiogenetics, and a comprehensive cardiomyopathy gene panel was performed that also included the mitochondrial DNA. And she was found to be homoplasmic for a known mutation at position 3303 C to T that's associated with a pediatric onset mitochondrial cardiomyopathy. So at that point, we became really, a number of us became involved. Further, we became really aggressive about making sure that this patient was as tightly managed as possible. She continued to follow with Reed and with the heart failure specialist who was added to the team. We put in a lot of precautions for avoiding metabolic stressors, avoiding fasting, dehydration, fever, and really promptly treating infections. So anytime she had a fever, anytime she was unwell, we would actually admit her to the hospital and treat her with IV fluids and really carefully monitor her. We also monitored other organ systems that we might be concerned, which could be involved in her situation and also contribute to her heart dysfunction. So we started very closely monitoring her thyroid systems, her thyroid, and to make sure she wasn't developing diabetes. We started her on a mitochondrial vitamin cocktail, including carnitine, because her carnitine was a little bit low, as well as an antioxidant mixture, and treated her metabolic acidosis. And we brought in other specialists. We have a physical therapist who works with our team, and she really specifically tailored a therapy program that she could tolerate from a cardiac standpoint, but also really helped to mobilize the muscles that she was able to work with. So really, these were a lot of the distal and small muscle groups, really helping her use her hands, work with the computer, and get around at school in a wheelchair. She was followed by ophthalmology, and we had mobility assistants really closely involved so she could get around in college by the time she got to school. So this really describes the team approach that was taken as soon as we really understood what was going on with this patient and what we needed to think about in terms of her overall management plan. And this brings me to sort of the start of the meat of our talk. And I'm going to begin just by briefly reviewing the role of the mitochondria in the heart. So as all of you probably know, the mitochondria produce the majority of the energy that the cells in the body need to function through the breakdown of sugars and fatty acids via a process of oxidative phosphorylation and fatty acid oxidation. Oxidative phosphorylation generates energy in the form of ATP, and changes in mitochondrial structure and function can cause oxidative phosphorylation to not function optimally and reduce the energy production that arises from that tissue. Other effects that occur when oxidative phosphorylation isn't optimal is an increase in oxidative stress, and that can cause downstream cellular damage. Changes in the way that calcium is processed in the cell, and this is incredibly important for the heart because calcium is involved in both cardiac contraction and the transduction of cardiac signals, and also alters the cellular response to stress. So if you think about the heart, it is a muscle that's contracting all of the time. So it requires a lot of energy. It's a high energy requiring tissue. And to go along with that, mitochondria, the organelle, account for 35% of the cardiac tissue volume. So 35% of the heart is actually made of mitochondria. At rest, the heart generates most of its energy via the breakdown of fatty acids in a process called beta oxidation. And when mitochondria aren't functioning properly, there may be decreased energy production that is unable to arise to the need when the heart has extra energy requirements, and also creates increased reactive oxygen species in the heart, which has downstream effects on heart function. So now I'm going to shift to the cardiac involvement that we would classically see overall in the population of primary mitochondrial diseases. So right now I'm not speaking about any specific individual disorder, but just about primary mitochondrial disorders as a whole. So cardiomyopathy, or a dysfunction in the way that the heart is squeezing, and arrhythmias, or difference in the way that rhythm is conducted through the heart, how the heart communicates for itself to beat in a coordinated fashion, are common in primary mitochondrial diseases. The estimated frequency of cardiac involvement across all primary mitochondrial diseases is anywhere between 20 to 50%. It's probably a little bit on the higher side in adults with mitochondrial disease and a little bit in the lower side in kids with primary mitochondrial disease. If you look at the bottom right picture of the heart there, where it says hypertrophic cardiomyopathy, this is the most common cardiomyopathy in primary mitochondrial diseases. And hypertrophic cardiomyopathy means, and if you can see it where the green arrow is pointing down there, that there's an enlargement of the tissue of that ventricle of the heart. The heart is, that part of it is hypertrophied and enlarged, and that can have various effects on the way that the heart functions. It makes the cardiac chamber itself smaller, so it has a lower volume for pumping blood. And sometimes it actually can be so hypertrophied that it actually impedes blood from getting out of the heart. But while this is the most common form of cardiomyopathy, many other forms of cardiomyopathy are seen. in individual mitochondrial disorders. So dilated cardiomyopathy, when the chambers of the heart enlarge, and squeezing of the chambers may not occur as well. Restrictive cardiomyopathy, where the heart itself is restricted in its movement, so it has a difficult time with both squeezing and relaxation. Left ventricular non-compaction, I have a little picture of that down on the right, and that's where some of the muscular parts of the ventricle of the heart are sort of spongier than they should be and can collect blood in some of those spongy parts. And there's other forms of cardiomyopathy as well. And as I hope I've gotten across to you, that cardiomyopathy and arrhythmia, which we're going to talk about a little bit later in the presentation, are important causes of illness and death in primary mitochondrial disorders. So in looking at the sort of population of patients with primary mitochondrial disorders and what cardiac disease means within those conditions, it's been shown that cardiac involvement is really an independent predictor of both morbidity or illness, hospital admission, and early mortality, contributing to early death across mitochondrial disorders. And because of that, cardiac involvement should be evaluated in all patients, regardless of whether or not they have cardiac symptoms, whether or not they're presenting with cardiac symptoms. If a patient is diagnosed with or even suspected of having a primary mitochondrial disorder, the cardiac system really should be evaluated right up front. And this is incredibly important also to note, and I've seen this happen in patients who have come to us and following patients over time, that heart dysfunction can really be asymptomatic until patients really can reach an advanced stage of cardiac dysfunction. And a lot of this has to do with a lot of overlay. So it may be that that somebody already has some myopathy and they don't recognize that some of the increased fatigue they're having is coming from their heart situation, or that it's just something where their heart is able to function just enough that they're not having symptoms until very late in the process. And the thing that can really make this tricky, even within individual disorders, that the age of onset, the symptoms that present, and the range of severity of other organ involvement is really, really variable from patient to patient. So this is something that we take a lot of care with. So I'm going to just go over some general treatment recommendations for mitochondrial cardiomyopathy. Again, these are not recommendations that are specific to any given disorder. This is how we would treat a patient where either we were sure they had a primary mitochondrial disorder, but hadn't yet differentiated out what type that was, or frankly, across many of the primary mitochondrial disorders once we've differentiated which type. So we do recommend, if possible, treatment at a tertiary care center with experience with mitochondrial diseases. And we know that this is not something that's possible in many geographical locations, but there are many centers that I know are open to consulting with your local physicians, local cardiologists, and really help them work through how to manage and treat these disorders early on. We recommend, of course, baseline assessments. So as soon as a primary mitochondrial disorder is suspected or diagnosed, evaluating for rhythm abnormalities with a simple 12-lead electrocardiogram, an ultrasound of the heart to look at the heart structure and squeeze through an echocardiogram, and a 24-hour Holter monitor. This is something that I'm really generally very liberal about recommending, but especially in patients who are high risk. So those who are already having problems with the squeeze of their heart with cardiomyopathy, and patients who are having symptoms. Heart racing, absolutely any patient who has had fainting, any patient who has near fainting, or is having sort of these paroxysmal events where maybe they're having some symptoms of just feeling unwell intermittently, or feeling maybe a little dissociated intermittently. The cardiac evaluation, and particularly a thorough evaluation for rhythm abnormality, should be done. In terms of follow-up for cardiac monitoring in primary mitochondrial diseases, so I'm going to start out with patients who are asymptomatic. I still, in every patient, recommend an annual assessment. And this includes a clinical evaluation by a cardiologist, monitoring of blood pressure, a yearly electrocardiogram to look at rhythm, and a yearly echocardiogram. Over time, with the consultation of an experienced cardiologist in a patient who has remained asymptomatic for a very long time, and all of these tests are normal over the period of a few years, it is possible to extend the interval of cardiac monitoring in patients who don't have cardiac involvement, but not something that is early on until we better understand what's going on with each individual patient. And of course, this is self-evident, but I'm going to say it anyway, is that patients who have cardiac symptoms are at increased risk. We're going to recommend more frequent follow-up, more thorough follow-up, and possibly other extended types of cardiac evaluations, which we're going to touch on in a little bit. In sort of helping to preserve heart function, even when there is cardiac dysfunction as associated with that primary mitochondrial disease, we do what we can to sort of control all the other aspects that can contribute to cardiac dysfunction. So these are things that can be quite common in the population, and particularly common as people age. And that includes treating high blood pressure, treating diabetes, treating high cholesterol and triglycerides, and just making sure we're doing everything we can to support that heart and keep it as healthy as possible. There's some other diagnostic modalities for evaluating heart function that are really monitoring heart function that are really coming more and more into play as time goes on. Something that we're utilizing more and more is cardiac MRI. This is something that should be very much considered in patients where the echocardiogram, we think it's not telling us everything we need to see. Where we're concerned that there may have been something that has sort of remodeled the heart or caused scarring. That's something that a cardiac MRI is going to be very helpful in assessing, and something that an echocardiogram is not going to certainly tell us the story. And to precisely quantify what's going in the heart if something invasive is being considered. So if there's any invasive procedures, anything that we're going to do surgically, really doing cardiac MRI to best define the anatomy is key. I'm going to touch a little bit on exercise testing and stress echocardiography. This is something that can be beneficial in some settings to understand an oxygen consumption and exercise tolerance and oxygen utilization in given patients. But this is something that we really emphasize should be done under very close monitoring with practitioners who have a lot of expertise in this area to be sure that this is done in the safest setting possible. And now I'm going to turn the talk over to Dr. Thompson.
Hi, everyone. Thank you, Hillary. And thank you to the organizers for inviting me and my colleagues to speak to you tonight. It's a real pleasure. And I was just going to reflect a little bit on the case that Dr. Vernon presented, because it was instructive to our group, and she came to our attention not that many, but a number of years ago, where we weren't automatically getting gene testing on any new patient with cardiomyopathy. But I think what we're actually, you can go back to the other slide. What we're now finding is, and when a new patient does come in with cardiomyopathy, we really do want to have a genetic diagnosis as much as possible. The other thing that was interesting about her, so she had hypertrophic cardiomyopathy, but her symptoms were out of proportion to the heart disease as we saw it. And the other thing about the heart disease, though she had hypertrophic, which is a thick cardiac muscle wall, the squeeze of her heart was becoming abnormal, which is a very end-stage phenomena that sometimes happens with hypertrophic cardiomyopathy due to the more common cause of that, which are problems with the sarcomere, mutations in the sarcomere genes. And an end-stage result is that the heart squeeze becomes abnormal. But she, at a young age, seemed to have that. So really didn't fit the typical pattern. She did end up going to biopsy first, and that's how we became suspicious, because her mitochondria were abnormal. And then the genetic testing led to a precise diagnosis. But that certainly made a lot of difference in the way we approached her, because we brought in all the specialties. We paid attention to her metabolic system. We had an explanation for the way that she differed from the typical presentation of the more common types of hypertrophic cardiomyopathy. So, that's something that has changed very rapidly. And probably one of my fellows asked me what's the biggest change that's happened in cardiology in the last 10 years. And to me, it is really this precise ability to define the cardiomyopathies in a way that we have not had an ability to do before. And that already is resulting in refinement of treatment, if not a specific treatment for that disease, at least a better knowledge about all the other things that are going on, the prognosis, and really how to counsel the patient. So very important. Here I just have in this slide that I borrowed from the Heart Journal because I thought it was instructive in just showing some of the things that can occur. Hillary talked about the problems with the electrocardiogram that you can pick up in the electrocardiogram that involve conduction of the impulse through the heart as well as arrhythmias. And here they're showing that there's a short interval between this wave and that wave. It's called a short PR interval. And sometimes this can also be in the setting of a thing called Wolff-Parkinson-White, which we'll talk about later. And that can be common in some of the mitochondrial diseases. Here we have an echocardiogram picture here and here showing the very thick muscle of the septum between the left ventricle and the right ventricle. Here is actually the wall on the right ventricular side showing that it's much thinner walled. And here on the left ventricular side, you see how thick it is, very thick all the way around. And in hypertrophic cardiomyopathy due to mitochondrial diseases, as opposed to the other more common cause, the septum is usually fairly symmetrical. And in the other diseases, very asymmetrical often. That's a tip off. And the other thing that we don't see much in the mitochondrial diseases is hypertrophic cardiomyopathy that's obstructive, so-called HOCM. And that is interesting because HOCM can be something that affects symptoms and risk of sudden death and things of that nature. And we like to sort of look at ways to reduce the amount of obstruction. And those typically don't pertain in the mitochondrial patients that have hypertrophic cardiomyopathy. It's more of a symmetric, non-obstructive version, still can cause symptoms, and it can be a good reason to start medications to help with that. Here's an MRI, and this shows it's actually a separate patient that has a different disease, but it is mitochondrial disease. And it shows that though not particularly thick, there is this light up after giving a dye to the heart called gadolinium. And this post-injection enhancement of that part of the wall shows that there's some fibrosis there. That is where there's some scar tissue. And that is another sign of the fact that there's a cardiomyopathy going on. And that may be something to know about when it comes to predicting the chance of having arrhythmias and what we do about that. And we're going to talk about that in a minute here. Okay, next slide. So the treatment of cardiomyopathy for the primary mitochondrial disorders really depends on what type of cardiomyopathy there is and whether or not there are symptoms that we think are due to that cardiomyopathy. And medications are used as well as in some cases devices. And so they're, as I said, specific for the type of cardiomyopathy we have, but aside from that, we have very few mitochondrial cardiomyopathy specific treatments that are designed to go after exactly what is going on in the mitochondrium. We are investigating some, but what we typically reach for are medicines and potentially devices that are known and have been shown in large clinical trials in other types of cardiomyopathy that are other diseases that cause similar types of cardiomyopathy. And those are the medications we typically use. And in some cases, we might make adjustments based on what we know about that specific disease. But for example, in HCM, which is hypertrophic cardiomyopathy, as I said, it's usually the non-obstructive type. It's usually a symmetrical versus an asymmetrical type of hypertrophy or thickening of the heart muscle. And in this type of cardiomyopathy, there can often be symptoms that are specifically related to exertion. And one of the reasons for that is that this thick heart doesn't relax very well, and it takes time to relax. And when the heart is beating faster, that time is less, the relaxation time is less, and so the heart cannot fill very well, F-I-L-L. And without filling well, it can't eject the normal stroke volume. So the typical approach is to control the heart rate when it is abnormally high, and there are symptoms we think that we can attribute to that. We lower them with beta blockers typically, or a thing called a class of medications called calcium channel blockers, or there is a very specific medication just to lower the heart rate by having effect on the sinus node of Aberdeen, which may be used if we're not achieving the lower heart rates that we're trying to with these other medications. But that also all of these needs to be used with caution in a patient that, in addition to having a risk for cardiomyopathy, may have a risk for progressive conduction system abnormality, and I'm going to talk about that next, which is not really the problem in patients with the other type, more common type of hypertrophic cardiomyopathy, or not necessarily the case for patients with dilated cardiomyopathy. So it's really very, very important before using these medications that you know as specifically as possible what to expect in the particular Mito cardiomyopathy you're dealing with in terms of conduction or arrhythmia. For the dilated cardiomyopathies, that means the heart is not particularly thicker than normal, though the total cardiac mass may be elevated because the heart has gotten larger. The left side of the heart has dilated, and as a result of many factors, either because of scar tissue or, in this case, malfunctioning mitochondria, does not squeeze well. And the squeeze results in decreased ejection fraction that lowers the output and also results in symptoms. And for this group of cardiomyopathies, we reach for the guideline-directed medical therapies, which would typically include a class of medications called ACE inhibitor, angiotensin converting enzyme inhibitors, or a related class that works in the same pathways, angiotensin receptor blockade, and the new medication, newer medication, not as new now, Entresto, is a combination of that with another small molecule that results, sacubitril, which results in better control over increased volume, blood volume. And then spironolactone or equivalent medications have been shown to be helpful in heart failure due to the dilated cardiomyopathy type. And if needed, diuretics may be used mainly for symptom control. Finally, there may be a need for pacemaker therapy, and those pacemakers can do not only the work of controlling the heart rate when there's a conduction problem, but may also, in certain instances, be used to control the timing of the contraction of the left and the right ventricle, which can improve output. That's called resynchronization therapy. ICD, a cardiac defibrillator, may be something to think about if there's a high risk of having a potential lethal arrhythmia, such as ventricular tachycardia or ventricular fibrillation. And then finally, heart transplant may be considered if either the dilated cardiomyopathy has gotten to the point that the patient is severely affected, or even the hypertrophic cardiomyopathy severely affected, or having severe arrhythmias that can't really be controlled by medications or devices. Next slide, please. Now, just a couple of slides about conduction abnormalities. We talked first about the structural abnormalities that can be affected in mitochondrial disease, that can be due to mitochondrial disease. But let's look now a little bit at the conduction system and the arrhythmias that we can see. Next slide, please. So these, again, depending on what exact diagnosis there is, may or may not, there may or may not be a risk for a conduction abnormality or an arrhythmia, but they can be common and a very serious cause of death, particularly in the Kern-Sayre syndrome, and also in the 3243 A to G mutation patients. These arrhythmias or conduction problems need to be recognized early on, especially in Kearns-Sayre syndrome, because the progression can be very rapid, much more rapid in other things that affect the conduction system. And we've now progressed our thinking to the point where if we see any change in the conduction system in Kearns-Sayre, we say that really it's probably time to be thinking about a pacemaker for them. Overall, the conduction defects have been reported in more than 10% of patients with primary mitochondrial disorders. Wolff, Parkinson, White, I mentioned looking for that. That can be diagnosed on an EKG, a 12-lead EKG. But seeing the abnormality on the EKG does not necessarily mean the patient will have arrhythmias, for arrhythmia being an abnormal heart beating or a risk of sudden death. But it is something we need to follow and really look for symptoms. And patients with these disorders should really let their physician know if they're having abnormal, sudden onset, rapid heart beating or palpitations that start suddenly and end suddenly. And that's apart from just feeling your heart gradually beating faster or slower, which a lot of patients have. When they have arrhythmias, it's a sudden onset and a sudden stop. Incomplete bundle branch block or AV blocks, these are what we pick up on the EKGs. And we're very vigilant about repeating EKGs. We now actually have ways of doing that even from home. We have a company that we're currently working with that will actually send a little kit to the home patient. We can get a 12-lead EKG, which allows us to look in every lead, not just in one lead or not just from your Apple Watch, what's going on. We can look at all the leads and see how that conduction system looks. So that's kind of an exciting development. Premature ventricular tract contractions might be benign, but if they're frequent and they actually increase with exercise, these are extra heartbeats, which some people can experience, some people don't. We just pick it up on monitoring. They can be a sign of a worsening risk of a lethal arrhythmia. And then pre-excitation, we talked about that. That's the delta wave seen on WPW syndrome. Next slide, please. So how do we surveil for this? Well, yes, we can repeat the Holter monitor. We now know that the 24 hours and even the 48 hour are not as good as the 72 hour. So we typically do a 3-day Holter monitor. It's very easy to do now. It's a patch that goes, many of you probably have had this, goes on the skin under your clothing. There's no wire, there are no wires, there's no little monitor to drag around with you. And that should be done relatively frequent. It depends on the disease, depends on the risk, and depends on the symptoms. But we should be looking with those, particularly in the patient that has a lower ejection fraction. So in the dilated cardiomyopathies or in the hypertrophic cardiomyopathy that is not squeezing very well, as in our patient, they're at higher risk for those serious arrhythmias the lower the ejection fraction. So we'll step up the surveillance based on that. There was already a question about diastolic dysfunction. Yes, we see diastolic dysfunction in all the cardiomyopathies, but in particular the ones that still have good systolic function. They may have impaired diastolic function, which has implications for symptoms for sure. And palpitations would be a sign that we need to monitor maybe in a different way. We mentioned Kearns-Sayre. They have a high risk of heart block. About 50% will go on to have heart block that can result in sudden death if it happens relatively suddenly and you're not aware of that. So we're very vigilant about watching their conduction system. And then we can have this high risk of ventricular pre-excitation in the M3243 A to G patients. Not all have a high risk of arrhythmia, but ventricular pre-excitation can be seen, and we just have to sort out what the risks are, which is quite important to do. We can even risk stratify through an electrophysiology study to see if we can create not only the arrhythmia, but see how rapidly those pathways that are the result of a that cause the WPW pattern on EKG, if those pathways can conduct very rapidly, we think that patient may be at risk not just for the SVT arrhythmia, but for ventricular fibrillation. And then in terms of what newer technologies we now have, there was a question about wearables. And yes, they're becoming a very real and potentially useful thing. Everybody's probably heard about diagnosing AFib on the wearable. Well, I've also had a lot of patients that have sent me rhythms that we didn't think were interpretable, but recently I did have someone send me a rhythm from their Apple Watch, and there was AFib on it, and so we're reacting to that as well. So that's helpful. And the internal loop recorders that can be implanted with just a little local anesthesia, and it's a very simple outpatient procedure. Those can last up to 5 years. And that nice thing about that, you don't have to be staring at your watch. They're just recording whatever's happening to the heart. They're not doing anything about it, but they're recording it and sending it through your phone to a central monitoring center that will then alert us if there is something very important on that. And we have been using that data to schedule people for defibrillators or to really increase our surveillance in other ways, or our medications. So very important, the new monitoring systems. I think that's all I was going to say at this point, but we'll be around for questions at the end. Next slide, just to make sure I'm done with my part. Oh yeah, one more. So yeah, what do we do if we think that the SVT, for example, is causing trouble that's not responsive to medications? Well, there's a procedure called an ablation, where we can go in with a catheter, find the pathway, use a little radio frequency heat, and cause that pathway to melt. That can be very effective. And it also, is something that we would only use though if medications were either not being well tolerated or were not effective at controlling the rhythm. We, as I said, have low threshold for putting a pacemaker in if there's a high risk of conduction system problems. And then for a defibrillator, it can be life-saving in certain instances, again, depending on what the overall picture is. And I'm going to show you, I think I'm going to summarize a little bit of this with this last slide. Sorry. This is a consensus. Next slide, please. This is from a consensus document that just came out last year from the Heart Rhythm Society. And this is a pathway to consider for patients specifically with mitochondrial myopathies or Friedreich ataxia. And the green are the ones where the class of recommendation is considered the highest agreement among the participants in the conference that devised these recommendations. And they really go through a little bit of, I don't have to do it in detail, but what we should recommend for the patients in terms of pacemakers, or possibly pacemakers that can also resynchronize the heart when the squeeze is not good, or potentially pacemakers that can resynchronize the heart as well as defibrillate the heart. And it all sort of depends on, as you see, almost every one of these says, concordant with patient goals of care and clinical status. Very important in all these decisions, not just with mitochondrial diseases, but with other diseases that have a lot of additional non-cardiac issues going on. Before we just sort of say this is the right thing to do, we have to make sure this is what the patient really wants, given the surgery that might be involved in placing these devices, the potential for abnormal firing devices, things like that. And so it's really joint decision making. But this is just to show that really there has been a lot of improvement in recognition of when to place these devices. And so you potentially will be talking to your cardiologist about these things depending on what your status is. So I'm going to now pass back to Hillary
Thanks, Reed. So I'm just going to briefly discuss considerations in other disorders of mitochondrial dysfunction. Next slide. So I spent a lot of time talking about primary mitochondrial disorders, but there are other disorders involving mitochondrial intermediary metabolism, and it's kind of hard to know whether to classify these as primary or secondary disorders of mitochondrial dysfunction. But other areas where we have to be very careful with very similar precautions include Friedreich's ataxia, propionic acidemia, which is an organic acidemia that very commonly has a dilated form of cardiomyopathy as patients get older. Barth syndrome, which is a disorder that Reed and Rebecca and myself spend a lot of time working on, is a disorder of mitochondrial cardiolipin abnormalities. And these are patients who can even have prenatal onset of a dilated cardiomyopathy or dilated cardiomyopathy at any point in their life that can actually remodel into a hypertrophic cardiomyopathy. Primary carnitine deficiency is actually one of these forms of a mitochondrial metabolic cardiomyopathy that can be treated. It's something that can be detected on the newborn screen, and if patients are really appropriately supplemented with carnitine throughout their lives, this is a highly, highly treatable form of mitochondrial metabolic cardiomyopathy, and something we really, really, really obviously don't want to miss because the treatment is so specific and so dramatic. And then there's the mitochondrial tRNA synthetase disorders, something that we really didn't have time to touch upon, but a group of disorders that affect the way that amino acids are put together and put on proteins in the mitochondria. And this is now an ever expanding group of mitochondrial disorders. I feel like every time I look in the literature, there's a new one being described, and there's a lot of cardiac involvement in those disorders. Next slide. So this is something that I really talk about with a lot of my colleagues, particularly when I'm talking to colleagues who maybe aren't as familiar with mitochondrial disorders, colleagues who are haven't seen a patient with a mitochondrial disorder, or a lot of general questions I get when I give a lecture, like how would I pick out a patient who had this? How would I know if someone coming to my clinic with sort of non-specific symptoms, how would I know to think about a mitochondrial cardiomyopathy? And this is sort of the party line that I give to a lot of my colleagues, is that when you see a patient, whether this is an infant, a child, a teenager, an adult, who has involvement of multiple organ systems that are affected, and there really is nothing that's unifying this diagnosis. So for example, a patient who has hearing loss and diabetes, or eye findings and seizures, or liver findings and heart findings, really that's when to consider a mitochondrial disorder. And in that process of considering a mitochondrial disorder, the heart should be evaluated. And particularly in the setting of, and Rebecca's going to talk about this a little bit, if there's a family history of cardiomyopathy, and particularly if that family history is running through the maternal lineage, but sometimes that can be really hard to pick out. When a patient presents at a young age with either isolated heart dysfunction or multi-system organ dysfunction with heart dysfunction, I really feel that mitochondrial disease should be high on that differential, high on that list, and investigated very thoroughly, because there's a lot that we can do and a lot that we need to do. Oftentimes I get this question from colleagues and from families, are there any specific lab values that can help bring attention to the fact that a patient might have a mitochondrial disorder? Something that we really didn't talk about, I didn't talk about much with the case that I presented earlier. What actually eventually brought this patient to genetics clinic was in the process of regular lab work for her heart dysfunction. It was found that she had an elevated total creatine kinase, an elevated CK, something that we wouldn't expect in an isolated cardiomyopathy. And that was what sort of led us to understand that her skeletal muscle is involved as well. So patients who have cardiac involvement in an elevated creatine kinase, mitochondrial disease should be considered. Of course, elevated lactate, lactic acidosis, and changes in transaminases. So sometimes we call these liver function tests, but actually they can often reflect muscle breakdown and muscle regeneration. So sometimes I've had patients referred for abnormal liver functions. And when we get down to it, when we get to the nitty gritty, their liver's fine. Those enzymes are actually coming from their muscle, and they end up having a skeletal cardiomyopathy caused by a primary mitochondrial disease. So something that, we try to be very, very careful about paying attention to. Next slide. So now I'm going to turn this over to Rebecca to talk about genetic counseling considerations in mitochondrial cardiomyopathy.
Great. Well, thank you everybody for having me. as I've been introduced, I'm a genetic counselor, and I work both with Dr. Vernon and Dr. Thompson in this metabolic clinic at Kennedy Krieger, but I'm also part of the Center for Inherited Heart Disease at Johns Hopkins, so I see patients with inherited heart conditions as well. And they asked me to kind of join tonight. I'm going to just give some really, I think, the big highlights of some of the genetic counseling considerations that I thought would be important to touch on. So the first is really around inheritance. And, when we're talking about primary mitochondrial disorders, we are thinking, most people are going to think, first of all, sort of mitochondrial inheritance. So that maternal inheritance, meaning there's a change in the mitochondrial DNA. And, essentially that means that the mother is going to pass that genetic change to all of her children. So there's going to be a very high recurrence risk for future siblings of an affected child. As kind of alluded to earlier, it is always very important to keep in mind that mitochondrial DNA disorders have a lot of very unique principles about them that are beyond, what we have the time to go into today. But those unique principles really lead to a very dramatic inter and intra-familial variation in symptoms, onset, presentation. So just because one individual within a family presents with very classic, let's say, Milas disease or MRF, does not mean that you should not look very, very closely at other relatives within the family, because there can be such variability. From other mitochondrial disorders inheritance standpoint, mitochondrial DNA deletions are usually sporadic, whereas a lot of the other mitochondrial DNA changes are maternal, inherited from the mother. It is important to mention, though, that not all mitochondrial disorders are caused by changes in the mitochondrial DNA. There are some primary mitochondrial disorders that are caused by changes in the nuclear DNA, and the nuclear DNA come equally from both mother and father. And so therefore, there can be other inheritance patterns, such as autosomal dominant, autosomal recessive, and even X-linked inheritance patterns. When you're thinking about inheritance, one of the reasons that genetic testing and sort of understanding that inheritance can be important is because of sometimes providing recurrence risk information that families may want to consider in the context of future family planning decisions. There are many family planning options when there are genetic conditions that are being caused by nuclear DNA changes. Unfortunately, there are a lot of challenges and very limited options for individuals who have changes related to changes in the mitochondrial DNA. In fact, the only real known family planning option in that situation is something called mitochondrial transfer therapy, which is not currently available in the United States at all. Another big piece of thinking about inheritance is around family risk and recommendations. When you're in this situation, this is where I think a thorough family history does become very important, and also education to the family members about the variability that can go along with these conditions. It is not uncommon at all for Dr. Vernon and I and Dr. Thompson for us to see a patient where a diagnosis is made. We kind of get the history, I'm getting the family history, and very clearly we're saying, yeah, that uncle, yeah, he's probably got this, that aunt, yep. So it is not uncommon for there to be sort of this variable presentation showing up in the family. And that's important then for healthcare for those other individuals as well. Next slide. The other thing I wanted to touch on briefly is genetic testing. And so this presentation tonight is kind of coming at it from sort of the cardiac perspective. And so it really depends on how you present as to sort of what, testing options might come first. And often the differential, sort of what the doctor is thinking, is really going to guide the test selection and the lab usage. Many patients might get their diagnosis from sort of pure mitochondrial DNA sequencing. Other patients may come at their diagnosis from a panel that could be a cardiomyopathy panel, as was described in our case tonight, could be a seizure panel. There are many ways that patients might come about a diagnosis, and often even these days exome sequencing, and coming soon genome sequencing even more. It is important to know that not all labs offer mitochondrial DNA genes and DNA analysis as part of their panels. So a cardiomyopathy panel, for example, at one lab may have none of the mitochondrial DNA genes on it. And if you have a high suspicion of mitochondrial DNA, then it is very important to make sure that the lab is being chosen kind of with that in mind. And as families kind of living this world, and having been through genetic testing, you're probably very familiar that, not all genetic testing comes back with nice, clear, positive results. You can get negative results that don't necessarily rule out an underlying genetic cause, and there can also be what are called variants of uncertain significance, which means changes in the DNA that aren't always exactly clear if they're causal or just maybe a benign variation that was identified. And then just briefly, another big thing to just be mindful of through sort of this process is the psychological and emotional factors that can come into play with, primary mitochondrial diseases and cardiac conditions specifically. A few of the biggies that come up are grief and in all of its many forms, not just actual loss grief, but sort of anticipatory grief and many different types of grief. Anxiety and guilt as well can be a big emotion that are present. When we're thinking about cardiac issues and mitochondrial disorders as well, it's also to acknowledge sort of the progressive nature of this diagnosis. And so the emotions that might be there at one point in time come to kind of terms with them, but as the disease progresses or things change, those emotions just come right back around. So it can be a cycle of these different emotions kind of floating in and floating out of the lifespan for this family. And then also just in cardiac specifically, the idea of ICDs, implantable devices, cardiac arrest risk, all of these things have inappropriate firing of ICDs, which is not as big of an issue as it used to be, but can still happen. All of these things, there are quite a bit of sort of emotional issues that can arise around them. So again, just very quickly kind of summarizing some of the things, but wanted to leave a lot of time for questions for everybody. So I think that's my last slide. And I think we have references here at the end. I was going to say, Hillary, Reed, are you guys coming back on the field questions with me?
Yeah,
sure. These were slides that we knew that there were a couple of questions about COVID or post COVID, long COVID, and the heart, and if in this audience may have their own experiences with that. I can imagine there may be a predisposition in some patients with mitochondrial disease to having long COVID, or at least experiencing some of the symptoms associated with that. I know there was at least one question in the audience. Did anybody else want to answer a specific question, or I can work through a little bit of this? I'll just carry on with that because I know that was one of the questions. If you can just go to, I don't know, skip that one. This is just potential mechanisms of the post-acute COVID phase, or the so-called long haulers. This is something that came out last year in Journal of American College of Cardiology, just a way of summarizing some of the information to date with long COVID. And you can see on the left, I don't think I have a pointer. This is not doing anything, right, Rebecca? If I move this, yeah, but it doesn't matter. On the left, there's you have the COVID severity, and presumably those with more severe COVID are more at risk for long COVID symptoms, but not necessarily so. And then susceptibility, interestingly, is higher in females, and particularly those aged 30 to 45, that also have maybe some abnormal immune response or autonomic system, nervous system response. The genetics are probably important. Underlying health status is important. And then other factors, as you see below. But interestingly, in this sort of cycle that gets set up with the fatigue and decreased exercise capacity and excessive tachycardia or fast heartbeat, there's also this orthostatic intolerance and this inability to stand upright or exercise upright. And they think that a large part of that is the bed rest, the inactivity that's associated with having COVID and being someone who's susceptible to the deconditioning that results from that. And that deconditioning then lowers the blood volume and decreases the stroke volume of the heart. And so you get this compensatory tachycardia, and then that further limits the exercise. So you never really get out of that deconditioned bed rest sort of state. And anyway, I just point that out as something that might be more of a problem for people with mitochondrial disorders. I don't know that. I think that is being looked at. I think there's some information that the mitochondria are involved. People are working on that. And that one of the recommendations is to start with more recumbent exercise instead of immediately trying to exercise standing up and work your way back up to. But certainly that's out of my field of expertise, but that's just something I did find that has come out recently.
Well, thank you all very much. I learned a lot during this talk, and I have a few questions. We're a little bit short on time, but I think we can squeeze a few in real quick. One question that came up multiple times is, what causes scarring in the heart?
Yeah, that is a very good question. I think it's depending on what the disease is, you can find scarring. For example, if you have a low blood flow, like with an MI, an infarction, you will have areas of the tissue that have poor blood flow, and those cells die and they're replaced by fibrosis. We also find it in patients with hypertrophic cardiomyopathy, and presumably there also is some limitation of blood supply to some of the very thick areas of the heart, which might result in scar tissue, but also in cases of inflammation of the heart after myocarditis, for example, or in muscular dystrophy. We think that there is an inflammatory process that happens with the cell permeability to calcium. And so the exact mechanism, again, probably depends on how the heart is affected by the mitochondrial disorder, but the scar tissue itself can mean that those areas don't contract well and are more susceptible to being nidus, a focus of an arrhythmia. And there's quite a lot of work going on at Hopkins to try to map out areas of scar tissue in certain diseases and then predict who's at higher risk for arrhythmia by doing a sort of a virtual electrophysiology study using that information.
Well, thank you. That is very interesting, and it sounds like many ways your heart can get the scarring can occur. Here's another question that I thought would be broad and for everyone. Are there any heart-related medications that Mito patients should use with caution?
Well, I was just going to say the ones that we might typically use for one cardiac problem, such as hypertrophic cardiomyopathy, might need to be used with caution if those patients are also at risk for conduction abnormalities, where slowing the heart may just not be the right thing to do at all. So yes, I think, again, it goes back to what their specific risks are.
Here's a question that I think our families would be interested in. How do patients go about finding a qualified cardiologist that's even heard of Mito before?
I'll try to start with this one, Reed, and then I'll pass this on to you. I think a lot of it really does depend. So just to start out, there are 17 mitochondrial medicine centers that are spread out throughout the United States. And looking at the Mitochondrial Medicine Center website, you can find some of these places, but this really isn't geographically easy for a lot of people. And so oftentimes for families who live in areas, even out of the country, places where they just can't, they don't have someone local. What's really important actually is finding someone who's willing to listen and willing to learn and willing to consult with an expert. So I'm not going to volunteer everybody out, but I know I'm always willing to talk to anybody who's calling from any place and say, this is what I would recommend. I'm happy to review this with you. This is what would be next. This is what you should consider. And as long as someone is willing to listen, I think that's the most important thing going forward.
Do you have anything to add, Dr. Thompson?
Well, I was just going to say, so some of these diseases are common in childhood, but yet may not be recognized until adulthood. So sometimes you find that expertise in pediatric cardiac centers that have a large heart failure program. And then, the ones that have typical adult presentation, I again look at places that have either an active research program in genetic cardiomyopathies would be a way to find the expertise there. And then if you find it, but you can't travel to those places, sometimes, mostly people that are interested in this sort of thing are very happy and willing to know about a patient, because the patient, the diseases are rare. There are not that many patients out there. Most people are very happy to talk about it. I myself, when we are faced with someone with a new disease that we've not encountered ourselves because it's so rare, we reach out, we find out who's written about the problem, we reach out, and people are more than willing to share their information and maybe not make specific recommendations for those patients because we really can't do that, but at least generally help.
I also would encourage our families to be sure to make sure that their cardiologist knows about Mito University. We have some really quality products on there that are free CMEs for doctors. And I think it's a way that if a doctor did want to know a little bit more, they could get to it there. I have one last question that's just was on my mind. Are there any advancements in terms of heart treatments for Mito patients that you see coming down the pike? Is there anything that you know of that you think we should be looking out for?
I'll start and then I'll pass this on to Reed as well. One thing that I have noticed has been extremely beneficial just in terms of monitoring for a lot of my patients, and particularly those who have a lot of mixed symptoms with things like anxiety and questions of arrhythmia, is actually looking at the cardiac implantable loop recorders. This is something that's recently becoming a lot more commonly used and has really provided, in a lot of cases, a lot of reassurance for patients who are having actually something other than an arrhythmia, but it has actually caught a lot of things in a number of other patients. So in my mind, for the patient management that I do on a regular basis, this has been an extremely helpful advancement in cardiac monitoring.
Yeah, in terms of therapeutics, I did mention that, there is interest in really now treating relatively specifically, but treating the mitochondria itself with a medication that is really targeted to certain parts of the whole mitochondrial problem that is going on specifically with the patient, but also advances just in those general heart failure medications that really seem to work no matter what, at least in some cases, no matter what the cause of the dysfunction is. And so they're really kind of some remarkable advances that are going on in hypertrophic cardiomyopathy for patients that have obstruction, for example, that help with symptoms, as well as those with dilated cardiomyopathy, finding that the drugs used for patients with diabetes can actually really improve symptoms in patients with heart failure. And that's now becoming just one of the class 1 agents to go to, even with only mild dysfunction sometimes. So I think really there are a lot of medicines coming to market now that are very promising, and we think we're going to really get to before even things like gene therapy and that sort of thing.
And I
Well,
would
that's
add that
great.
there's also some studies of medicines that have been around and very well established being started to use in different sort of aspects. So like the Vanish trial, Reed, and sort of using that early and sort of very early stages and signs of hypertrophic cardiomyopathy. I don't know, that's so new, that data is very new. Whether or not that's going to apply to our Mito patients too will be interesting to see. But I know it's starting to be used in, different applications too.
Yeah, I mean, and that goes to, I think there was a question about what can be done about fibrosis. There are some medications that really are now using in other diseases that specifically help, we think, prevent fibrosis, and that may be one of the effects that we're seeing for the angiotensin receptor blockers and hypertrophic cardiomyopathy, to really target the whole fibrotic pathway. TGF-beta is one of those very important molecules in that pathway, and there are medications that can inhibit that process. And we're looking exactly for those medicines that have been on the shelf and been approved for a very long time, and then have these other properties. And what we typically will do in these rare diseases, since it's hard to do a randomized controlled trial, you don't have enough patients, is things that make sense. That we think we could do safely, we could try safely, that don't have an obvious negative effect. We might be willing to try in a patient with this mitochondrial type cardiomyopathy.
Well, that's exciting news. It sounds like we have some things coming down the pike. Today, we're about to wrap up, and if your question wasn't answered, we will do our best to get them answered post-event. I want to make sure everyone knows about our next Ask the Mito Doc. We're going to be talking about clinical trial readiness. Very important topic. And then in April, we're going to be talking about endocrine complications. So please mark your calendar for March 22nd and April 25th to join us for our next installment of the Ask the Mito Doc webcast series. I want to thank Rebecca McClellan, Dr. Thompson, and Dr. Vernon for joining us today. This is going to be an important enduring material that will sit on MitoU for our families, and will be on our YouTube channel. And anyone that's registered for this meeting should get an email when the recording is complete and ready, but it should be up in a couple days to a week. So thank you again, and we hope to see everyone, except for you, Dr. Vernon, because we're going to be having fun, at Mitochondrial Medicine 2023.
Thank you.